Hi everyone, I'm John Barratt. I'm a Professor of Renal Medicine from the University of Leicester in the UK, and it's my great pleasure today to be joined by a good friend of mine, Richard Lafayette. I'll hand over to Richard to introduce himself.
Hi, I'm Rich Lafayette. I'm a professor of medicine at Stanford and work in the Glomerular Disease Clinic and Center here.
And so what we thought we'd do over the next 15 to 20 minutes is really just chat through the challenges we face currently in managing patients with IgA nephropathy. And Rich, I wonder if you'd mind just taking us through perhaps the last patient that you saw in your clinic with IgA and the kind of thought that were going through your head about the challenges of looking after them and what you had on offer really to prevent the progression of their kidney disease.
Yeah, that would be a great start. So I'll jump right in with a recent patient that I had who was a late 30s-year-old man from China, actually, who now lives out in California. And he had been diagnosed by biopsy with IgA nephropathy a year ago. His biopsy had shown a good amount of activity and just one focal sclerotic lesion. He didn't have much in the way of chronicity. He was a fit young guy, and his creatinine was about 1.1 milligrams per deciliter. So just under 100 microliters per whatever units you guys use. And he was feeling very, very well. He had been maximized on irbesartan, in fact, and was tolerating it well with blood pressures of about 120/70. But he had been spilling about 2 grams a day of proteinuria. He had blood in the urine, and he was worried what to do. He had already seen other physicians and had undertaken a course of prednisone at 40 milligrams a day for 3 months. It didn't look like his proteinuria came down more than 5%, and he had tapered off and was really wondering what he might want to do next. And so this became difficult. I think I'll turn it back to you to talk more about prognostic issues, but we looked at things like his international IgA nephropathy risk predictor and said with 2 grams of proteinuria, active lesions, he looked like his prognosis was not perfect. Again, after the RAS inhibition, he's still sitting around 2 grams. After prednisone, still around 2 grams. So we really talked about what else we could do. Again, he was already exercising. He was a non-smoker. He was trying to eat well, getting used to the California diet, so trying to stay nice and low salt, not too much protein in his diet. Work was very stressful, so we talked about reducing work stress a little bit, but it mainly focused on what to do. And this is a very bright, engaged person who runs back and forth from China. And so he was wondering whether he should take hydroxychloroquine, another course of steroids, should take mycophenolate, or whether newer medications would be better for him. And I think it's really, really tough because I did approach it in a way saying, well, it looks like conservative measures were already done. His blood pressure was well controlled. I was really worried about not treating him more aggressively, but he had failed corticosteroids, which I may not have treated him with personally myself first. But looking at a way to control that inflammation was really, really difficult. We went through first the conservative care and thought about whether we could increase his RAS inhibitors further, but he was on a solid dose. Sometimes after exercise, he felt a little dizzy and lightheaded. So we said maybe we shouldn't do that. We considered SGLT2 inhibitors, but as his blood pressure was well controlled and his kidney function well preserved, I thought we should really focus on the active disease in the kidney more so. So we did talk about other opportunities like dual endothelin angiotensin II receptor antagonism, but again, the blood pressure was pretty good and wanted to make sure that we were really looking at the inflammation. We did come around to talk about mycophenolate in people of Chinese origin as a possibility, but we also talked about looking at Nefecon because this seems to be a good opportunity where he looked just like a lot of the patients in the Nefecon trial, And I tried to suggest that that would be a good idea. At the same time, we talked about several open clinical trials that we had right now. Presently, there were phase 3 trials looking at B-cell modifying agents, and thought that that could be a really good option for him. As you know, the early data is spectacular. We don't yet have complement blockers, and it was in a sort of area where my trials for complement blockers weren't active. So that was another consideration. But he was concerned about the placebo-controlled nature. And so we did start out and give him a prescription for Nefecon. And we're still in the phase of sort of waiting to see what happens. Very early on, he's tolerating it well without side effects. But that's just an example of where we started to, and we could discuss sort of more situations because I have some more advanced patients, some brand new patients as well. But I just wonder if you would have handled this differently, and if whether the sort of playing field's a little bit different in Europe and UK. So
Yeah, I mean, I think that's a great case, Richard, because it kind of summarizes all the challenges we're going to face. Previously, we didn't really have any challenges, did we? Because we didn't have anything to offer our patients. We've now starting to see new opportunities. And I think just running through the case, you looked at optimizing supportive care, but as with my patients, young patients really don't have significant hypertension, and he's starting to get symptomatic when he exercises. So you really do have your hands tied behind your back in terms of what do you do about that RAS inhibitor? Do you increase it? Do you add an SGLT2? Could he tolerate an additional endothelin receptor antagonist? But of course, you want him to stay active. You don't want him feeling dizzy. You don't want him falling over. And I think that's going to be something we're going to have to grapple with in our young patients with IgA. And we have all these other therapies coming in around the supportive care envelope, and we may have MRAs as well. But will our patients tolerate all of them? That's going to be a really interesting challenge. We don't have sparsentan in the UK yet, but it is coming, and we've had patients on the trial, and they do very well. But we just need to think how we balance that. And I don't know what you think. We've traditionally always said RAS first, but do you think when we think about the supportive therapy, do you think there's an opportunity to start thinking, well, perhaps should it be an SGLT2 first rather than a RAS, or should it be an endothelin receptor antagonist first, if we're going to be limited by blood pressure in our young patients? Or should we go for 5 milligrams of ramipril, 5 milligrams of DAPA, half dose of sparsentan to get a little bit of everything in? How do you think that might evolve? Because it's not going to be a challenge we're going to face in diabetic kidney disease, where we're dealing predominantly with older people with already established hypertension, where they can probably throw the kitchen sink at them and their blood pressure won't go down too low.
yeah, I find that really hard to make a decision about, because having had experience of only having the angiotensin 2 receptor blockers or ACE inhibitors, I've grown very familiar with them and happy to use them. And so I'd like to start with them, maximize them, really see early at 2 or 3 months, whether or not I'm having a big impact on the patients, an adequate impact, and whether they're tolerating them for the blood pressure effects and potassium and creatinine, of course. So I'm just used to doing that. And as you know, the trials for all the others are add-on trials. So it's hard to really know what would happen going first. There are now some trials looking at the sparsentan approach first, and it looks like it's really well tolerated and leads to really nice proteinuria reduction. But we're still a little sensitive to cost issues and dual agent issues. So I think we need a little more experience in terms of really trying to comprehend from the trials which one is the best by itself. I think it's hard to say so far. And there is that sort of desire to say, give a little bit of everything and inhibit all of those nasty pathways that are leading to glomerular and tubular interstitial injury. But we just don't know if that's really true, whether really a maximal endothelin blockade will do just as well as a little bit of everything else. And you could just substitute any of those agents or mechanisms for the other and say, we just need to learn. So hopefully companies will do trials like this, or we'll gather together in our international IgA network perhaps, and look at some comparative approaches and get more insights.
Yeah, I mean, I think we are seeing combination trials, aren't we, at the moment? But I think that is going to be a really important question for us. Well, I'd be interested in your thoughts. One concern I have is by reducing proteinuria with these hemodynamic agents, do we worry that we lose the only biomarker we've got for actually immune-mediated glomerular inflammation and damage? And we're lulling ourselves into a false sense of security that by dropping the glomerular pressure, we are reducing proteinuria and almost masking potentially ongoing immune-mediated glomerular damage, because we don't really have another good biomarker. And I don't know what your thoughts are on that. I mean, I don't know how we tease that out until we have new biomarkers, but I'm always just a bit worried in the back of my mind. And certainly the data we saw in RADAR is that people with less than 0.5 gram of proteinuria, 1 in 4 of those developed kidney failure at 10 years. And was that because we thought we were doing so well that actually we were suppressing proteinuria hemodynamically, but they still had an active disease we weren't treating? I don't know what your thoughts are. I mean, I don't think it's a reason not to do what we're doing, but I just worry that we don't want to lull ourselves into a false sense of security that everything's fine because the proteinuria dropped down.
Yeah, I think it's a great point. I'm not so worried about hiding active disease by treating them well, because I still feel very confident that if we do a good job with conservative approaches and the patients tolerate them and the proteinuria goes low, you're still reaping benefits in every study seen so far. If you really get the proteinuria down, the patients do better. However, to the question is that good enough? And as you said in RADAR, sometimes it's certainly not good enough because people are still progressing merrily along. So I do like the approach of worrying, at least, that the conservative therapy isn't suppressing all of that glomerular inflammation. If you still see blood in the urine, if your biopsy is still showing a tendency to form crescents or have a lot of mesangial or endocapillary proliferation, or even interstitial nephritis, which we see sometimes as a marker of bad outcomes, clearly we need to do more. What that more is, I'm not sure. I've certainly moved away from systemic immunosuppression for a long time in my practice, but I think the tools we have now, ranging from Nefecon to hopefully soon being able to understand what these B-cell modifying drugs really, really do, and even other more targeted immunosuppressants, the judicious use of complement inhibition, I think we'll have the opportunity to really see how those combinations work. I'm pretty confident we'll do a lot better, and then we will know what to do. And, I'll turn it back around to you because, in other more rapidly progressive diseases, we always talk about time is nephrons, and we don't want to do our serial therapy. I still feel comfortable doing that, but I've heard you before suggest that maybe you do have to attack all these issues early and successfully at once. Are you starting to find the opportunity to do that?
Yeah, I mean, you've heard me talk before, and you've not fallen asleep a few times, so that's been quite good. I think, I mean, my view is based on the data we have in the UK, is that the lifetime risk of kidney failure is significant. And the fact that most patients present to us with impaired kidney function, having lost significant nephrons, means that we haven't got time to wait. And so I would prefer to simultaneously manage those hemodynamic issues alongside the immune issues. And it's interesting for the patient that you described, this young Chinese guy. He clearly had an active glomerular disease on the biopsy. He's not responded to systemic glucocorticoids, so he's had a pretty good treatment with a general broad spectrum anti-inflammatory. And then I guess the question is, you've elected to use Tarpeo because it has been shown to reduce pathogenic IgA and potentially be a disease modifying therapy, which is exactly what I would have done in this situation. If a complement inhibitor was around, and there may be one in the States approved in August, We don't know. But if it were, where would you think, would you add a complement inhibitor? If that was available now and affordable, would you combine that with Tarpeyo? Would you use one rather than the other? How would you think about those two fitting together?
Yeah, I think it's a question that doesn't quite have an answer yet, as again, we're learning about these agents more. I've been very impressed with the complement story. Again, the pathophysiology really shows an important role of complement in IgA nephropathy, and the early phase 2 data with various agents suggests a nice potent antiproteinuric effect, and again, very small data, GFR stabilizing effect. So I think working relatively downstream in IgA nephropathy, even if you have immune complexes getting to the kidney, if you can then prevent the damage by blocking complement, that's very attractive. For the moment, I mainly see it as an either or, and would say I'd either use a targeted budesonide or a B-cell modifiers if they come forward, or complement inhibition, except in a case where really the creatinine's going up maybe in front of my eyes in the face of overwhelming inflammation. So I talk about these as like RPGN light a little bit. They don't quite meet those definitions, but you're really worried about rapid progression and irreversible loss. And there would be very attractive to look at something like Nefecon plus a complement inhibitor, or a B-cell modifier plus a complement inhibitor, at least for a short time, and see whether or not you get better benefits together than you would by themselves.
Yeah, and you mentioned B-cell modifiers and BAFF and APRIL a number of times, and I agree there's a lot of activity in this space, isn't there? So I'm going to give you a nice and easy question. So you were the lead author on the rituximab paper, and I think you showed quite nicely that you were able to deplete peripheral CD20 cells, but actually that had no effect on in IgA nephropathy patients clinically or on pathogenic biomarkers. So why do you think a BAFF and APRIL approach is showing such promise when a CD20 depletion approach, which we know works beautifully in ANCA-associated vasculitis and PLA2R membranous, why do you think there's a difference there? And what does that tell us about the disease?
Yeah, I think it tells us that the action point for making galactose-deficient IgA and antibodies to galactose-deficient IgA doesn't really reside in that active CD20 pool, at least not the circulating one. So I think the beauty of BAFF and APRILs, inhibiting those agents, is they work really in various spots very early on in B-cell development, early on in B-cell class switching, which is really critical from going from IgG, IgM production to IgA production, and then very late as well at plasma cells at keeping them surviving. So I think the effect, particularly on these products of galactose-deficient IgA and on the anti-glycan antibodies, is likely just to be a lot more potent than our at least old school anti-CD20s. So it'll be exciting to see what a more complete depleter might do in this disease. It will, of course, be interesting to see what direct anti-plasma cell therapy will do. But the proof's in the pudding that the anti-APRIL or the anti-APRIL BAFF combination is just really effective at dropping serum IgA levels, and it really looks to impact this disease in a very nice and thankfully so far well-tolerated fashion.
Yeah, I mean, I agree with you. The data's been incredibly strong, and I think what's really nice is the fact we've got multiple agents, and they're almost validating each other, aren't they, in terms of the data we're seeing. So I think for the listeners, that pathway, the BAFF-APRIL pathway, looks really exciting as a way of managing the production of pathogenic IgA. But of course, with efficacy comes safety. So in terms of your thoughts on if these drugs were available, how would you be thinking about them? And what would you kind of be thinking you needed to monitor for, think about in terms of managing this young lad who clearly is out and about doing lots of things, coming into contact with whoever knows, traveling to China regularly. How are you going to think about the BAFF-APRIL inhibitors in the context of someone like him and the kind of things you might worry about, or you might tell him, or you might monitor?
Yeah, again, so far, the programs have looked really, really promising. They've delivered on showing results in terms of efficacy, as you mentioned, without major safety concerns. However, across the agents that IgA is substantially reduced, IgM is substantially reduced, luckily with evidence that you can still respond to vaccines and that your previous vaccinated agents, if you provide them with a mitogen, they still can respond. So that's really reassuring that they don't lose their vaccine history, and hopefully that means they don't lose their other antimicrobial memory and that they can still respond. And so far, that's what we're seeing. However, I think across the board, if we're even targeting budesonide and they get some steroid effects, if we utilize complement inhibition, if we're using B-cell modifiers, we have to be respectful that they are having an impact. And just, we're going to learn these drugs a lot more. We're going to ask people to be safe. I think we've learned so much about the world in COVID that just asking patients to sort of reiterate that degree of safety, wash their hands a little bit more often, wear masks in crowds, stay away from people who are obviously unwell. I think that's going to advantage this whole program of all immunomodulators, that you can just be a little bit more cautious. The patients all know what you're talking about now. And I think that's the degree of safety. Obviously, for all these phase 3 programs, we want proof in the pudding that they look as safe as earlier development. And then when we get personal experience, we'll see what happens with our patients.
Yeah, and so, I mean, I think what we've been discussing really, I think, illustrates to the listeners the challenges, or the exciting, I would say exciting challenges we're going to face over the next 5 to 10 years is all of these new drugs, many of which we've not prescribed to patients before, certainly not to IgA nephropathy patients. We're going to have to get used ourselves, aren't we, to how we use them, how we combine them. We're going to have to think as an academic community about combination studies, because it may not be something that pharmaceutical companies will want or be able to support. So I think we are going to need to utilize the expertise in centers like your own, the Glomerular Disease Center, where you're going to get much more experience of these drugs and the combinations of these drugs, look where for patients presenting with this disease. And that's certainly something we're thinking of in the UK, because a lot of practicing nephrologists don't see that many IgA nephropathy patients, and a fraction of those are going to need these therapies. So we really need to think how we might coordinate and share knowledge and learn as we go, really, in a way that benefits our patients. So it'll be fascinating to repeat this conversation next year, the year after, and the year after that, because I think each year we're going to have new drugs to talk about, aren't we, Richard?
Yeah.
And I think we're going to have to be on our toes to educate our colleagues about the ins and outs of how we use these in clinical practice and what we've learned from the phase 3 and the post-marketing studies, because we're going to get new knowledge all the time from these agents, aren't we?
Yeah, I think, one of the nice adjectives I'd like to use is dynamic, and we can be a dynamic duo together.
I'm
But
not
I
sure
think
who's Batman and who's Robin. I'm not, and don't answer that, Richard.
we could sort that out later. But I think the important thing is that, that dynamic change is that there are new medicines, there are new interventions. So we have to be on our toes to really first understand the disease is more dynamic than we ever thought. People don't just sit there and slowly progress out into old age. They have unfortunate events and come to kidney failure much quicker than we previously thought. We now have choices, and we need to evaluate them by biopsy, see what the patient's risks really are. And then we can't just start a therapy and have them come back in another year. You have to really evaluate whether they're getting to your goals, whether they're responding, whether they're tolerating the drug, because now you have second or third options to either change to or add on to. So you really, really have to be ready. And then, as you mentioned, every 3, 6, 9 months now, there may be another opportunity to put the patient either in a trial or use another approved drug. So you have to be ready for that change and learn them and be educated about that and spread your learning and experience to the rest of the world. So it really is a great, great time, but it's going to keep us on our toes, ready to learn, ready to act. And, I welcome it. I think it'll be great.
Fantastic. Well, look, it's been an absolute pleasure spending the last 20 minutes or so talking to you. And Thank you very much to the listeners for listening, and I'm sure you'll hear more from the dynamic duo in due course. Bye-bye.
Bye.